Thank you, Tim. One of the briefs to me was to bring a little bit of my personal story. So there's not a lot about the details of my research, and I think probably listening to what we heard today, we've heard everything from a real range from some of Nicole's data on MDTs in lung that really don't have much of a data strategy, through to Kwan Fong and Barbara Page, who are secretly going to take over Australia. And I guess this story, probably the context or where this story can contribute, is to how our MDT and our data strategies, if you can call it that, have developed. And they've developed absolutely along with me, because I founded the MDT, and that's just what happened. It wasn't any, I didn't have strategy for a long time, if ever. So I'm going to talk about the start, how we've thought about data, which a lot of it hasn't been very structured over the years, building the team, how the research evolution from our MDT has evolved, pivotal moments in my experience, some reflections, and then thinking about MDTs from research to practice, and I guess practice to research and research to practice again. So I saw a clinical gap years and years and years ago at St Vincent's. We didn't actually have a lung MDT, and I informally surveyed the relevant clinicians. I simply rang them up, told them who I was, were they interested, and every single person said yes. So we booked a room and a date, and we got going. And I'd spent a year at the North Shore MDT, and any North Shoreys will recognise the old brick building here, which has been modernised. I haven't actually been in the new building, but I've heard it's fantastic. Our first day was the 5th of July 2006, and I remember it well, but I don't have a lovely letter to show you. I wish I had. So our MDT data started in 2006, and I'm kind of relieved that we started collecting. We just put it on a spreadsheet, which I've lost, but and I can't actually even remember what we put on, but we certainly collected names and dates of birth, and so we do have everybody. And then a lot of this was accidental, and when I was preparing this talk, I was sort of horrified and amused to see how accidental this was, particularly, and I think that might be informative because I am absolutely a clinician, and I do have this secret love of data, which I didn't know about for a long time, but I think most clinicians, there's some brilliant people, some of who are in this room and some like one, but generally that's exceptional. Most clinicians are clueless about data, and about just clueless, and I was. And so we went from a spreadsheet to Microsoft Access, and that was kindly drawn up for us by the local clinical cancer registry person. And I didn't even know what the local clinical cancer registry was, and she didn't really know what I wanted because I didn't know what I wanted, and she put something together which we worked with for a long time, and I even went and did an Access course. And then 5 years into our life, I bumped into somebody in the corridor of thoracic medicine who said, "Do you want a database?" And it turned out that in my very own department, Cardiothoracic Services were running a FileMaker Pro embedded integrated hospital database that was in a room next to my office and I didn't know about. I just can't believe these things sometimes. But anyway, we made a good move, which was to dump our data across into FileMaker, and it's now integrated, has ethics approval, has some data input from the electronic health record, and it does upload to the local ClinCR, which has now turned into New South Wales Cancer Registry at some point, I'm not quite sure when. And the best way to describe this experience is as if I was crashing through a forest blindfold, guided by people who had a torch which lit a very small part of the forest that they knew about, but they didn't actually know much about the rest of the forest. And that's really how it felt for a lot of the time. And I think that maybe quite a few clinicians feel the same about data. I eventually started to think about data mapping, and I've drawn this on one of my posters, and this isn't the be-all and end-all, but it's one of the ways I understand how data sources interact. And in the middle, this is New South Wales. It's not as good as Queensland, but it's what we got. New South Wales Cancer Registry's in the middle, and ClinCR did feed into that, but it's now turned into the Cancer Registry. So those two can go together, and then there's a radiation oncology system and the oncology systems. I don't think anybody has any confidence that data comes in from the private system, at least that's my understanding, and that's certainly the case at St Vincent's. And then there's various other systems, and then our MDT is somewhere over here and fed into ClinCR, but now directly into the Cancer Registry. For me, it was useful to start putting those dimensions around the data because it's really not part of clinical medical training. We just don't get it. We just don't have any information on that. I guess motivated people go out and find it, but it's just not part of what we do in clinical medicine. projects, I had to think about what mapped into ClinCR. We can replace ClinCR with New South Wales Cancer Registry. And just for St Vincent's, it gets a little complicated. There's many sources. There is our MDT, there's MediWeb, which is St Vincent's electronic health record, there's DeLacy, which is the St Vincent's public electronic health record, which fits under MediWeb. But for example, if the junior medical officers look things up in DeLacy, I don't know why this is the case, there's a whole lot of stuff in MediWeb that they don't see. So they will see all the public, if they look up, say, one of my patients and they just use DeLacy, and because our system is not very good at integrating everything, they will see some information, they will see the public hospital information about a patient, and that may not capture anatomical pathology done in the private, and they'll say, oh no, they haven't had a biopsy, and I tell them to look at MediWeb and boom, up pops the biopsy because it's done in the building next door. So that's really, and my junior staff don't understand that distinction in the data sources, and I only found out by accident. Corpaz is the administrative stuff, the palliative, PCS is the palliative care stuff, which feeds in, Shoma told me this I think, from Calvary, Prince of Wales, Royal Hospital for Women, a couple of others. And so for example, if we were looking for death data for our MDT patients, pulling out through ClinCR / New South Wales Cancer Registry, we could get it if they died at St Vincent's or at some of those other hospitals, but not necessarily otherwise. And then there's the oncology management system. So for a clinician who doesn't have access to Cool, data can be very difficult and frustrating. So I have a dream, which is MDT data, and maybe Cool is the answer to this. If it was implemented nationwide, I don't know. But you can see the Jupiter-sized proportions of MDT databases is how I view their importance. And then everything else is a little smaller and a little bit more peripheral. But for me, clinicians, and maybe this will influence our panel discussion, will be part of it, the MDT data, our interface with the MDT data is how the clinician will understand what's going on with the patient, the care, the service, etc. And I think from the clinical point of view, many data sources are very unknown, not identified, and the linkage strategies are completely opaque. And that some of the things I'm doing with my PhD is trying to fill in some of those gaps and to clarify things and to, I guess, identify ways we can, for research, for feedback and for understanding, fill in the gaps for clinicians. How did I build my team? Probably the way most people do. The clinical team fell together naturally. We had all you saw Barbara's list of specialists. We have a very similar group. Probably a little smaller, but the same range of specialties. And we started every 2 weeks, and a couple of years in, bumped up to weekly. And I was lucky enough to get a development grant from the Cancer Institute after about a year. And then since then, I've employed senior medical students to enter the data and write the reports. And that's been really successful because they're very motivated. They actually get paid, which they love, but they also get an opportunity to do lots of other things. It took us a few years to get a good MDT coordinator. And talking earlier, we don't send our reports out to GPs. We haven't thought through some of the issues they've thought through in Queensland about whether they want to. We want to, we think, but we don't have anybody to lick the stamp, so they don't go. And the other thing I did when I was building the MDT was to go on what I called a study tour, which was some visits around Sydney to Prince Alfred, I'd been to North Shore, to Nepean, just to see how the teams worked, really in terms of collegiality, how the chairing went. And the other thing I did, I spent a day at ATS hassling American MDT leaders in an opportunity that I missed to do research. I just had chats, but I spoke to people from the VA system, from Mass General, from MD Anderson and from UCSD, and I just said, which cases do you take to your meeting? And I loved it. They were all different, and they're tussling with very similar things to us in case selection. So VA took everybody. Mass General do 2 cases and a didactic session. MD Anderson, I can't remember, and the Californian said, we only do 3A. We just talk about 3A because they're the ones that need the talking about. And I thought that was fascinating because it's universal, all the questions we're dealing with. How did the research evolve? Well, all of the MDT research for lung at St Vincent's, I think, comes from me. I've got a really great group of clinicians, but they've got other research interests. And this is my trajectory. I won't bore you too much with my life, but a long time ago I got my FRACP and I thought I was pretty good. And so I started a PhD, which was really bad, which is probably my fault. It was laboratory based and it turned into a master's. And then nothing happened research-wise, but you can see that instantly I finished my master's degree. I got bored, so I started the MDT. And then years and years later, in a funny kind of way, I started a PhD. Several major life events happened early on. They're all at school and eating a lot. And then I had an opportunity to review my publications because I was always secretly before, later on, just horrified at my terrible publication record. But purely because I've been working with all these wonderful people, things have improved and I've had some pivotal moments. So the light bulb moment was starting the MDT. That very first star was getting the development grant. That look of shock was when I had to send my CV to somebody to join a grant and I thought, I better do something about my research career. And then the next star was having a chat with my Conan Corish at the Garvan, some of you will know, who looked at me and said, you should do a PhD, and I nearly fell off my seat. And then I thought, okay. So I emailed Kwan, who said, sure, what's the topic? And I went quiet for 6 months. And then I went to a Cancer Institute Symposium and heard Nicole talking about something or other that I thought was fascinating, and I rugby tackled her afterwards. And then I had a meeting with Tim and Nicole and several others to talk about some of our data. And within 36 hours, I was enrolled as a PhD student with these two. Yeah, and I was horrified afterwards. I didn't sleep for a night. I haven't told you this, but I'd often reflected on my master's degree and thought I just didn't do my research and I didn't think hard enough, and I thought I really should have checked this team out better, but it was too late. And anyway, it's been fine. And then there's two other pivotal moments. One was being asked to join the International Association for Lung Cancer Tobacco Control Committee. Tobacco control has nothing to do with my PhD, but it's given me a lot of writing opportunities and a lot of opportunities to hassle famous American people. And then the latest pivotal moment was getting a grant from St Vincent's, which has given me some research time and funded somebody to do some of my clinical work. And all of that has added up to the evolution of my research, which is how I've been able to push our MDT program along. And we've had lots and lots of poster presentations. These are all my research assistants and registrars, and there's another half dozen to add to that. And I haven't published any PhD papers, but I promise I'm writing them. But we've done this, which wasn't really an MDT data paper, but emerged from some work I'd done on looking at biomarker results in our MDT group, and joined with the Nepean MDT group and published that. And we were very pleased and privileged to contribute to Nicole and Tim's paper and Deborah's paper, which looked at evidence practice gaps in lung cancer, and our MDT participated in that, and the benefit we got was really understanding the gaps in our practice. And so research coming into the MDT can make a difference. So I was also asked to reflect about the journey and what would I do differently and how would I think, put this together maybe for somebody else. And as always, like everybody says, I wouldn't do anything differently because I don't think I'd be where I am without all of that failure and all of those mistakes. And it's been, especially the last 4 or 5 years, have been just amazing. And I never thought PhDs were enjoyable, but this one is. But if I was going to plan this sort of project for somebody else, and the Queensland work is very important here. I think a clinician engaging in MDT research needs a map of the data landscape, because most clinicians don't know it. They just don't have it. You need an immersion course in the language of data sets and linkage, and you probably need to spend a lot of time with people like you. I would give them phone numbers of key people, data custodians, everybody who's helped me from the Cancer Institute, various university researchers, clinical trial staff, and I would make sure I knew what kind of database activities were going on in my own department. And so the things that they would need would be all of those tools to help them really gain a better knowledge of data and what data can do. And this is clearly a developing field. PhDs are great because that's me on the surfboard, and Tim is in the helicopter and Nicole is on the beach, because they make you do things you don't think you possibly can. And the recent big wave I surfed was this Delphi Consensus Conference, where we're really trying to get a consensus process around the kind of data fields that are relevant for MDTs. And I invited about 30 of the best lung cancer MDT clinicians around the country to phone in after hours and talk to me for an hour and a half about data, and half of them did. I was terrified, Tim, I don't know if I told you, but anyway, we had a great discussion. We've got really good results, and we're pairing a couple of manuscripts, and I've just resubmitted for the clinician buyout grant with a project that's building on that. So to make MDTs work in research and practice in research, I thought about what is unique to MDTs, and I think it's the pooling of the resources. I think it's that interface position between clinicians and data, and I really think the MDT is that as a group. And I think there's potential, or perhaps even real eventuation with cool of very live data collection and feedback. And I think it's the interface where changes can be implemented very quickly. I think clinicians need the expertise of data researchers. We certainly need time. So this grant I have is pivotal. I think we need a sense of need. There are pockets of MDT resistance out there in surgeon land which need to be stamped out, and a sense of purpose about what MDTs can actually achieve. It shouldn't just be in a formal discussion, it should be a recommendation. I think it can be a recommendation, not mandatory, and it should be a source of information about your practice. And I think the clinical gaps need to be identified, and you identify that by collecting data, analysing it and reviewing it. Thanks very much.
Thanks very much. I hope I give good advice from the helicopter, not too high, but anyway, Nicole certainly is on the beach catching wave with you. So, anyway, so questions for Emily. I thought it was great, and thanks very much for being so open about your personal journey. Do people have questions before we move to a kind of briefish panel discussion? I mean, I think one of the key things about implementation science, where Nicole and I work, is that people like Emily are pivotal in this, because they're in the system. I think we need to encourage much more clinicians to take on this kind of research work, not necessarily to PhD, but to actually engage, because it's you that have the access. And I think if MDTs are going to be drivers, then there's that motivation for you to do that. It's a very big difference. Any questions for Emily?
Hi, I just wondered if you had a particular point of view about whether the MDT information for a patient should remain within the medical record, or if it's preferable for it to sit in a separate database or a separate place to the medical record.
Yeah, we upload ours to the medical record, and I think everything should be in the electronic health record, because I think all the information should be together. So I think I did while I was developing my data skills, we did do a bit of duplication, and we brought files into our database. I've stopped doing that. And then we would generate reports just sat in the MDT database. And then the reason they've become files that upload to the medical record is because our MDT program really got going at St Vincent's, and it's now a big MDT program, and everybody has to create and upload it. So we just went with that. But I think that's correct, because it's fantastic in the clinic, because I see the patient a week later, I can't remember. I'm the chair. I sign off. I can't remember what's in the MDT report. Click, it's in the medical record. I can see it. So I think it's really valuable. It's right there at point of care.